I'm Dr. Phillip Williams from Dallas. I'm chairman of the Archives Committee of the American Association of Neurological Surgeons. We're privileged today to be in Honolulu, Hawaii, attending the 51st Annual American Association of Neurological Surgeons meeting, the Harvey Cushing Society. We're also privileged to have Dr. Richard Schneider from Ann Arbor here today, who is not only the past president of this society, but one of the great neurosurgeons of our time. And the purpose of this is, you who viewed other tapes, is to have an opportunity to visit with some of our great leaders in neurosurgery, for them to reminisce on their years in practice, the opportunities that they had, the opportunities that they see for us who are to succeed them, and just to get to know some of the great men in neurosurgery. Dr. Schneider, we're delighted to have you with us today. And
thank you.
I'd like for you to tell us a little bit about yourself, your family, where you're from, your roots, so to speak, and your background, your education, anything you'd like to share that for us to get to know you better.
All right. I was born in Newark, New Jersey. My father was a physician. He was known as the German doctor in town at the time. There was quite a German group in the city. He spoke German as well as English. My mother was a home economics teacher. And I guess all as far back as I can remember, I wanted to be a doctor. I can remember going out and making house calls with my father in a sleigh, which he rented during the winter months. Seems the winters were worse then, but they're pretty bad right now. I went to Culver Military Academy in Indiana, and then went to Dartmouth College, where I got my AB, then to University of Pennsylvania Medical School, where I got my MD. While I was at Pennsylvania, I came under the influence of Dr. Isidore Ravden, who was chief of surgery. And my first contact with neurosurgery came about that time. Dr. Fraser was alive during my freshman year, although he was quite ill. And I do remember him, however, as a gentleman who was always immaculate. He went to despite his illness, he went to a graduate nurse's dance, and I had my first and my last view of him. Dr. Ravden was instrumental in helping me a great deal. I was president of the Undergraduate Medical Association at Penn, and we would have a speaker every month or so, and Dr. Ravden was the patron for the association. It was during one of these occasions he asked me who I'd like to have for a speaker, and I mentioned Dr. Wilder Penfield. And one of the great opportunities for a fourth-year student was to present the speaker, and I had this privilege of presenting Dr. Penfield from the podium when he addressed the student body. Dr. Ravden then was going to take me on as a general surgical resident. But unfortunately, he took a resident every other year, and he'd just taken one that year. I went to Newark City Hospital, where I interned for 2 years, and subsequently I went on to Cleveland City Hospital, where I was in pathology. My arrival in pathology there was kind of interesting, because when I got there, the FBI was going through the frames of the head of the section in pathology. This gentleman was a German name, had a father who was German, and he came from Newark, New Jersey. Consequently, I was immediately suspected of perhaps being involved as a Nazi spy. But the FBI was going through his frames and taking out all the maps of Cleveland, where the utilities were, the different important buildings around the city. And this was my reception there. While there, Pearl Harbor occurred on December 7th, and I had to decide whether I was going into neurosurgery, whether I was going to go into pathology or surgery then. I came to Detroit and was at Detroit Receiving for a year, and finally ended up as the last man in the surgery department. I had done some work cutting skin grafts freehand. We didn't have the machines at the time that we have now, And because of this, I was taken along as a plastic surgeon. I had no training in this. But we got over to North Africa and Italy and France, and there they were sending all of the plastic surgery home. We didn't set up our hospital, which was the 36th General Hospital, the Wayne unit. We did not set up in North Africa, and all the plastic surgery was sent home. So I got to the chief of thoracic surgery, chief of neurosurgery, who was John Webster, major, incidentally also trained at the University of Pennsylvania. And I said, if either one of you gentlemen need a hand on a retractor, I'd be very glad to work with you if I might. When we got into Italy, we set up our unit, and the first case that came in was a groom who'd been riding on a tank. He'd gotten a German bayonet through his maxillary arch, carried his right eye up into his left frontal lobe. Major Webster called me up and said, I need a little help. Do you want to hang on to a retractor? I said, yes. We worked on this man for a period of 6.5 hours under local anesthesia, taking a fasciolata graft and patching him up. And lo and behold, an hour later, we went down on rounds on the ward, and he had a small basin, had his 1 foot in the basin, washing himself, one eye patched up where his eye had been, and smiling. And to me, this was neurosurgery, and this is what I wanted to do the rest of my life.
That did it.
Yeah, that's right.
Well, you had your experience in neurosurgery then, and where did you go from there after the war?
After the war, I went to University of Michigan, where I had 2.25 years with Dr. Max Peet as the chief, and Dr. Kahn as the associate chief. And my training was for 2.5 more years. I was given credit for about 3.5 or 4 years of general surgery, 2 years of neurosurgery in the war, and then 2 years of residency, a little over that, at Michigan.
Tell us a little bit about Dr. Peet.
Dr. Peet was an amazing gentleman. He's a big man, size 9 gloves, and a very fast operator. He was an excellent general surgeon. He became quite famous for 2 operations. One of them was trigeminal neuralgia, the temporal approach, and it would be nothing for him to do 4 ticks in a morning. His speed was remarkable. I assisted him on one operation when Dr. Carl Rand came to visit him, and he said, Carl, I'm going to give you a stopwatch now. You hold on to this watch and we'll see how fast I can go. He finished the operation skin to skin in 11.5 minutes, which is just unbelievable. But he had a team that was used to helping him, and he really moved. He also is famous for splanchnectomy, and we did something like 3,200 splanchnectomies at Michigan. We haven't done one for 15 years because of the medication.
Then Dr. Kahn came along as the chief after Dr.
That's correct.
Retired.
I left Michigan and went to Cleveland and practiced 2 years. And I wanted to come back after a year. I wanted to come back to Michigan. Dr. Peet saw me and he said, you know, I'd like to have you back here, but I don't have room in the echelons of the service. I went back to Cleveland. I opened my own office, and it was only 2 weeks later that Dr. Peet died in the operating room.
He died in the operating room?
Well, in the scrub room right next to the operating room. And he had a little pain in his stomach, so he took a little Pepto-Bismol, and tragically, he just didn't survive. Because of this space on the ladder, Dr. Kahn became chief, and then he invited me back to Michigan, and I've been there since 1950.
I see. Dr. Kahn, can you reflect a little bit about your time with him, association?
A wonderful man, a very friendly man, a true gentleman, very careful about patients, His heart was always in the operative procedure and examining patients and looking after them. He was well known, I think, for his, probably most well known for his cordotomy, the open cordotomy, placement of lesions. He was the first man in the world to do a flap on a subdural hematoma in infants. He was well known for his work with thorotrast in brain abscesses, tapping the abscess and then putting in thorotrast to identify it on the x-ray. He was always a great deal of fun to be with, and just a wonderful chap.
About Dr. Crosby, I think one of the first exposures I had to neurosurgery as far as books were concerned is correlative neurosurgery, which you certainly contributed to, along with Dr. Crosby. Can you tell us a little bit about Dr. Elizabeth Crosby?
I could talk all the time about Dr. Elizabeth Crosby. She's 93 now. I first met her in 1946 and was a student under her while I was still a resident. And a truly remarkable lady with a photographic memory. I'd say to her, "Isn't it wonderful you have that memory?" She said, "I'll tell you, Dr. Schneider, it's a curse." She said, "I'd go in and look at something on the wall, an equation in high school. The answer was right there and never forget it." And she said, "You know, I'd have to unlearn all that and work back to get the answer." She's a wonderful little lady. She's just within the last week, she completed one of her own books on correlative comparative neuroanatomy of the telencephalon in vertebrates. As it was on Thursday, she received her first copy. On Friday, she received her first copy of our third edition of correlative neurosurgery, which she has done a major piece of the work on.
At age 93?
At the age of 93.
That's unbelievable. So this is April 1982, and
she still works
going.
8 to 4, 5 days a week, and on Saturday she comes in because it's quieter, and I spend about 4 hours with her every Saturday morning.
Well, you can't take anything for friends like that and opportunities that she certainly provided you and your associates.
That's right.
How about your particular interest in neurosurgery? When we think of spine and traumatic injuries to the spine, we think of Richard Schneider. Has that been your particular interest, or other aspects of neurosurgery that you developed?
Well, it's interesting. You become known for one thing, and then you try and get away from it a little bit. The thing I enjoy the most in the way of work has been seizure surgery. I've only done about, I think, 130 temporal lobectomies, probably 11 hemispherectomies, and some other focal, definitely focal seizures in very intractable cases, intractable all medication. And I suppose, I think this is probably the most rewarding of the things that I have done. Better than some meningiomas and better than some other cases that we do. The spine, I've spent a great deal of time on, it's true. And I've enjoyed it thoroughly. It was an area after World War II where it was sort of neglected. If you operated on a patient, you were still subject to criticism, particularly in broken necks. And consequently, I found a little area which other people were not involved in, and which I thought gave me a chance to do some primary work that perhaps other people had not done.
What would you say is your favorite operation?
I think probably a seizure case with good electrocorticography, depth electrode studies, and stimulation.
How about your most difficult operation?
Oh, I would say probably a tentorial meningioma, pretty much under the temporal lobe, extending through the tentorium, involving the lateral sinus, entering into the posterior fossa all the way down to the, perhaps the 12th nerve even, and removing it, trying to get it off of the sinus, save the vena galen, save all of the arteries and the cranial nerves in the posterior fossa. I think that was probably the most difficult one.
Is there an operation that you wish you'd never done?
There's no one of those. I think there are probably several of them, to be honest with you.
Okay. Well, it's 1982. What would you envision for neurosurgery, so much that have gone on the last 10 years with the CAT scan, and of course the advance of the microscope is used with almost every neurosurgical procedure today. How do you look at 1992 and year 2000, and say 50 years from now, what the neurosurgeon will be doing at that time?
Well, we've moved so fast in the last 5 years that it's pretty hard to foresee the future. But I would think if we're going to make advances, I think regionalization is going to have to come. This morning we heard a very interesting debate about the vascularity of the posterior fossa and operative procedures in that region. And you know, if you think back about these things, I can remember splanchnosectomy, 3,200 of them being done at Michigan. They're gone now. Medicine has taken care of it. I can think of trigeminal neuralgia, and it's not very often now that we have to do a patient with trigeminal neuralgia. I would think that possibly the vascular surgery that we're doing now, as was pointed up this morning by our neurologist, I think it was Dr. Don Eaton, is it? He pointed up the fact that perhaps we're going to be a little more conservative on that in the future, depending upon the findings of the various committees that have been selected to investigate the results. If we're going to do this, I think that we're going to have to be forced into a more confined area. I know most neurosurgeons that are in private practice don't like to hear this, but it's getting very expensive now with the CT scan, the laser, the neuromagnetic resonance machine. All of these things cost money. We're at a time when our economy is in trouble, and I would believe that in order to have the equipment and to have the numbers of cases available to make judgments about our results, that we're going to have to some way submit to some regionalization to accomplish this.
If you had to do it all over again, would you be a neurosurgeon?
Yes, I would. I forgot to tell you that I used to faint when I'd see the sight of blood. And it was a really difficult time. My internship, I perspired so freely that I had to put a student nurse behind me to wipe my brow. But I finally got over that, and but I think it's a challenging field. I think that the area is going to change a tremendous amount in the future.
Dr. Schneider, it's been a privilege for us to have an opportunity to visit with you and share your thoughts and reflections on your superb career in neurosurgery. And for those of us, I guess I can just take this opportunity to say thank you for what you've done for neurosurgery and making this a better life for us as well as our patients.
Thank you very much, Dr. Williams.